Hello. Hi, I'm Dr. Omar Bey, and welcome to OBHealthy and our Physicians Health Network. We're a group of Black physicians that are here for two reasons, two very important reasons. Number one is to improve the health of people of African descent. And number two is to encourage young Black males to go into medicine and the field of medicine because it's so important. Our webinar is every second Saturday of the month. So each month, the second Saturday, you can come on to OBHealthy and click the Physicians Network on the bridge and sign up and come in, and you will see us. And you can type in your medical question each month. Or if you don't want to type in a question, just listen, because it's all about education. It's all about improving our knowledge about medicine. The webinar, our past webinars can be viewed if you go on to OBHealthy and scroll to the bottom of the homepage. And you will see the YouTube sign. Just click the YouTube sign and our channel will come up and you will see all of our past webinars. Education is so important when it comes to your health. The number one thing that I can say today that's the most important is that do not change any aspect of your medical care until you consult your physician. That's so important. All righty. I think that's all I need to say to introduce us and get us going. So let's introduce the doctors who are here today and understand several more physicians will be joining. I know that they're busy this morning. Dr. Daniels is still in surgery, but he'll be joining us as well. Dr. Atherley, please introduce yourself.
Good afternoon, everyone. My name is Trevor Atherley. I'm a board-certified interventional cardiologist. I practice predominantly at Newark Beth Israel Medical Center. And part of my joy is, of course, being a member of the teaching service, training our young cardiologists. Thank you.
Dr. Patrick Anderson, please.
Hi, everyone. I'm Patrick Henderson. I'm a board-certified obstetrician gynecologist with a focus in gynecologic cancers. I treat women with cancers of the reproductive system, ovarian, fallopian tube, uterine, cervix, vaginal, vulvar cancer, and aid in the screening of breast cancers. I practice at Newark Beth Israel Medical Center with most of these honored panelists. I'm happy to be here.
All right, thank you. Dr. Jordan Garrison.
Hi, my name is the Honorable Ketanji Brown, and I've just been nominated to the Supreme Court. No, all right.
Excellent, excellent.
My name is Jordan Garrison, and I am a board-certified general vascular and bariatric surgery, presently practicing up in Hackensack and specializing at present in diseases of veins.
All right, thank you. Dr. James Court.
Dr. James Court. My practice is located in East Orange, New Jersey. I graduated of Howard University. I only treat adults. I don't operate, neither do I deliver babies.
Thank you very much. Dr. Nelson Aluya.
Yeah, good afternoon, everybody. It's a pleasure to be here once again with this great esteemed colleagues and brothers who are doing such an amazing job. My name is Nelson Aluya. I'm a medical advocate in medicine and pediatrics trained, an assistant professor of medicine at the New Jersey Medical School in Rutgers, New Jersey, Newark, New Jersey. It's a pleasure to be here again. Thank you.
All righty. Dr. Dwayne Fredericks.
Hey, good morning. My name is Dr. Dwayne Fredericks. I'm a bariatric surgeon. I specialize in obesity medicine, and my practice is in South Orange, and I just joined a group in North Bergen County, I'm sorry.
All righty, thank you very much. Dr. James Lee.
Good afternoon, Dr. James Lee Jr. I'm a second-generation board-certified orthopedic surgeon, fellowship trained in sports medicine, currently serve as team physician for East Orange campus football, as well as Bloomfield College. Proud to serve today.
All right, thank you very much. And Dr. Kevin Clark. Kevin.
Hi, good afternoon, everyone. Dr. Kevin Clark. I'm a surgical oncologist. I work at Newark Beth Israel with most of these distinguished gentlemen. Glad to be here.
All righty. Thank you very much, everyone. And thank you all the physicians for coming. I'm not going to forget this time. I'm Dr. Omar Bey. I'm a pulmonary critical care physician with subspecialty in nutrition. And just so happy to have all my brothers here with me so that we can bestow some medical knowledge. All righty. Again, I want to say is please do not change any aspects of your medical care until you consult your physician. That's the most important that we need to say today. All right, we're going to start off, and we have a lot to cover today. And what I'd like to start off with is Dr. Patrick Anderson talking a little bit about maternal health and Black maternal health, number one, and then we'll go into some other things as far as his field. But Patrick, can you start off? Maternal health is something that is so important. And in our community, we're finding that there's a bit of a problem with, our female survival, either during their pregnancy or after pregnancy. Can you enlighten us with this?
Yes, everyone. I'm glad to be here. One of my roles in all this is in our hospital community as one of the leaders. And we try to develop standards of care that improves patients' outcomes and their safety. As I know we all do in our respective specialties. We practice in a community where 80% of the patients we see are either Black or brown people. And in women's health, it's hard not to be a standout. The United States, unfortunately, as a developed country, probably has a maternal mortality rate of about as higher than most other developed countries. Some of the statistics I look at is, nearly 60% of all maternal deaths are preventable. And with the acumen and resources that we have, it boggles our minds all the time as to why such a high rate exists in the United States. And then when you look at our communities, the proverbial saying is, when everybody else gets the flu, we get a pneumonia. And that sometimes is hard to tolerate. And I think, there are many factors, but first it starts with how do we define maternal health? And we often focuses at the point of pregnancy, but we should remember that, before one becomes pregnant, they are in an unpregnant state and they're in a reproductive age group. And there are factors in the reproductive age range that influences what happens during pregnancy and after pregnancy. And many times, it's not just intrinsic health factors, which is, often the risk that you have acquired through genetics or social determinants, but also some of the ongoing stressors that changes in.
All righty, we have a weak connection there with Dr. Patrick Anderson. Hopefully he will come back in and give it a moment. All righty. Unfortunately, we have a weak connection, so give it a second. We can. All right, Patrick, are you back?
Yes.
All right, for some reason there for a minute, we lost you. Go ahead.
Yeah. So, as I was saying, we just came through a pandemic where, if we did not have issues then, we're having a lot of issues now. And it's both financial, social, mental health, and it all impacts on maternal mortality. This coming week, April 11th to the 17th, is considered Maternal Mortality Week. And many institutions that ranges from our hospitals to our community health centers have different programs that centers around screening, risk assessment, of patients to try and identify individuals who may be at risk for untoward outcome before, during, and after their pregnancies.
Yeah, yeah. You know, what are some of the high risk entities that Black females may be facing that put them in this category? I know, being a physician that deals with weight and deals with pulmonary, and I know from my perspective, it's you know, patients that are overweight. We think of respiratory problems. We think of the fact that the respiratory system is affected dramatically by patients' weight when they're very large. Are there other aspects that we should be concerned about? Maybe hypertension, diabetes, things like that, Patrick?
Yeah, well, you know, in my opinion, and some of my specialty colleagues, subspecialty colleagues may have other opinions and other ideas that add to what I might say. But I believe that, you know, obesity, hypertension, thromboembolic phenomenon, as in blood clotting entities, things such as mental health, things such as appropriate nutrition, I will not say malnutrition, but appropriate nutrition, all influence how one plan for and develop their engagement in conception, pregnancy, and the postpartum period. You know, I feel that oftentimes the standards that are written in the textbook as to what defines normality, you know, cannot be just put on a protocol and be followed. These standards need to be individualized to specific individuals. So if one define, you know, a normal blood pressure as, you know, 110/70, okay, and a young lady comes in and she's 110/70, then maybe the question should be asked, well, let me engage with your primary care provider to see what the pattern of your blood pressure is, because maybe she is someone who ran 90s/50s, and that 110/70 may have exceeded the definition for what's considered pregnancy-induced hypertension or preeclampsia. And so now that person who seemingly has normal parameters, maybe those parameters are not normal for that individual, right? So we've got to do some risk assessment, and the only way you can do risk assessment is to have a baseline for each and every individual that comes in. The hope is that, you know, with the appropriate utilization of electronic medical records, you know, we can access information from other sources as it pertains to specific individuals, and look at some of the other questions that has been posed to them by other healthcare providers who we may not deem important, but once that information becomes evident, we realize that it fits into a broader pattern that could influence where we take their healthcare.
Right, right. It's so
Okay.
important. Go ahead.
How early do you typically see these patients who come in for healthcare after being pregnant? Do they come in late, or do they come in soon after pregnancy? Will that impact on the mortality rate?
Yeah, well, we all know that late prenatal care does impact on your mortality rate. And how does that impact? It's the late diagnosis of pregnancy-induced hypertension, the late diagnosis of, you know, diabetes in pregnancy, and possibly the late diagnosis of some other immunologic things that we may be taking for granted. I think the bigger issue is, you know, what happens prior to some of these patients, prior to them becoming pregnant. And the truth of the matter is, it's not the majority of patients who are coming in for late prenatal care. All right. The data, I don't know specifically, but if I have to guess, I would say it's only about 20% of patients who come in for late prenatal care. Most women, when they do suspect that they're pregnant, they will reach out at least to be certain that they are not pregnant. So late prenatal care is only one one factor. Some of the things that we find, and it should not be a major factor, is, patients will get their prenatal care in one location and go for delivery in another location. And with appropriate systems and with, patient portal and access to their own medical records, they essentially should be walking with their medical records. So while it's not ideal to go from place to place, get your prenatal care in one place and deliver in another place, but the access to information should not be a hindrance to some of these patients.
While, Patrick, while we may say that there are certain diseases, and especially from my viewpoint, heart diseases, which can worsen the outcome of maternal health and even the fetus, we look at it also in the converse, that things that may be normal and physiological for the development of the pregnancy may in fact have an adverse effect on other pre-existing conditions. And we can go down the whole list of these, but I think that the physiologic increase in the volume of blood circulating during the first part of the pregnancy, the increase in the volume can have a harmful effect on certain of the heart diseases that we have. And just to mention a few things that we don't see very much of, but congenital heart disease, uncorrected holes in the heart, etc., that there may be a deleterious effect on some of the valvular disease, where there are valves that are either sticking and not opening properly, or opening and leaking inappropriately back into the chamber from which the blood came. So the insufficiency of valves or the stenosis or sticking of valves may be worsened in some instances by the increased volume and the stress of pregnancy. So patients who may have been well compensated and not even known of the heart disease may sometimes present for the first time with heart failure or other heart conditions, which have been elucidated during the course of what would have been thought to be an otherwise normal pregnancy. So not only does our heart, in fact, our hearts influence the outcome of the pregnancies, but your pregnancies influence the function of our hearts.
Yeah, and that's so true. Some of it is just the physical changes that occur, as in one, the increase in volume, which the heart must now pump fast, see a larger preload before it pumps. But one of the hormonal effect on the smooth muscle of the heart is it relaxes, right? So it changes the functionality with respect to the pumping, the robust pumping of the heart as the pregnancy progresses. That's one thing. The other thing is there's a physiologic anemia, which is the red cells, because of the increased volume, is now there's a dilutional effect. And as we know, with increased activity, the body calls for more oxygenation, and the way the body compensates is for the heart to pump faster and more forceful. And if you have a muscle that's physiologically a little bit weaker, pumping against a larger preload, then that could have some effect and could increase heart failure. And then, there is the whole pregnancy-induced cardiomyopathy, which is weakening of the heart muscle. I'm not going to sit there. Dr. Atherley probably knows more about this than I do, but from a general practice perspective, we know that this is one factor. But recognizing the symptoms of this, a young lady who, as the pregnancy progresses, especially if it's a gestational pregnancy, meaning more than one, twins or triplets, these physiologic changes are even more dramatic, right? And that compounded by the weight gain associated with pregnancy and the additional demand on the circulatory system to provide oxygen have additional stress to the heart. And then, the idea that, well, after we deliver, all this should go away. Well, it doesn't go away immediately because now you don't have that resistance that the placenta provide. Now that's taken away. The peripheral vascular resistance increases, right? So now the heart is even pumping against a different set of resistance. In addition to this, additional fluid volume is now dumped back into the maternal circulation, right? So it added additional stress to the heart. So, it's understanding the physiology and recognizing the changes that occur in many of these mothers albeit subtle, right? And identifying a change, it's almost closing a loop. You can't just identify it and say, well, it's there, it is what it is. You have to identify and follow the progress of these ladies.
I was just going to mention a little bit more on the specific disease process that you mentioned, Patrick, and quite rightly so. You mentioned what we call peripartum cardiomyopathy. This is where you may take patients who have not known of any heart disease, who have apparently normal functioning hearts, who in fact, in a normal pregnancy, a very small percentage of these patients may suffer damage to the heart muscle, such that during the last trimester of the pregnancy and in the first 3 months after the pregnancy, may for the first time present with what we call heart failure. This is one of those cardiomyopathies or disease of the muscle producing heart failure, which fortunately in many instances has a very good prognosis. Many times when my patients have cardiomyopathies and damage to the heart muscle, we know that the outcome may not be a fortunate one in the majority of them over the next 5-year period. Instead, however, in peripartum cardiomyopathies, we're at least hopeful that the outcome may be good. I say peripartum because there may be patients who go through the entire pregnancy and only after the pregnancy, in the first few months after the pregnancy, demonstrate signs of this heart failure. And at that point, we may do tests and may blame, in fact, the pregnancy on causing that. Thankfully, this is not a very frequent problem. Maybe Patrick can identify how often it occurs. I hardly see these problems nowadays in my practice, but it is a bothersome problem because it seems to occur in patients who do not have otherwise identified significant heart disease.
Yes.
If I may add something here to that.
Actually, I was, Dr. Aluya, I was going to go to you next, actually. From an internal medicine point of view,
right.
can you help us out as far as that's concerned?
Right. Yeah. Well, you guys know I'm big on global perspective and also on statistics. Before I begin, the question is this: is pregnancy a disease or natural state? And what are the confounding factors that predisposes an individual or female who's pregnant to complications that may result in death? When we talk about, maternal mortality is from, I think the time of pregnancy up to like about 6 weeks afterwards. Dr. Henderson will know better that definition. So it's not just, you're pregnant and you give birth, but up to a certain time after you give birth as well. I think 6 weeks. I don't. That's the number. But then, it has a disease or normal state. Now, the confounding factors I'll take from individual. For instance, why is it more in the numbers are worse in African Americans or people of African descent than those who are not? A whole lot of other reasons. In fact, one, before I go to a global perspective, is the structure of our pelvis. I mean, back in the days, we were taught that the shape of the Black female's pelvis is acute, like this, and that of the Caucasian, somebody else, others are obtuse. So the issue of difficult delivery and a baby being stuck in the birth canal is so much worse for an acute pelvis as compared to those with an obtuse pelvis. So, but that's one of the factors that begin to relate with as we understand some of all these things as well. And knowing that in our community as well, some of our women tend to give birth at a younger age group or get pregnant a younger age group than even other age groups as well, for other social issues and other things that come around with it. Now, what's the statistics? Globally, I think 2020, 2021, it said that 152 or 53 deaths per 100,000 worldwide. That's the mortality rate. Here in the United States, in 1919, I think it was like 20, but 2020, it went up to about 23.5 or so. And it's worse even on us. Maybe COVID contributed to that as well. Now, if you break it down to, non-Hispanic Blacks and Blacks, we are about 3 times worse than non-Hispanic Blacks. So why in the United States about 23 per 100,000, to us is 55.2 or 3 per 100,000, and that's huge. And we all know that studies have also shown that if you're a Black woman who's pregnant to deliver in this country, you're about 4 times at risk of dying from that pregnancy, irrespective of your socioeconomic status or your level of education. And that's it's open, it's out there. So the question now is, what do we begin to do? How do we begin to address these issues? And I'm glad that we have Dr. Anderson and all of us who are here. I call myself a medical advocate because that's what we need to do. We need to first of all go out there like we're doing, identify, engage, inform, and educate our communities about the risk factors that predispose them to disease and death, even in pregnancy. Now, coming to disease itself, big issue, obesity, it's a big issue. Our statistics in our community is so much more compared to others, either because of the food we eat and everything else. And I was talking to somebody today when I drew, the GI gut of a Black person as compared to African American as compared to an African in the African continent based on the food that they eat. And when it was swapped, huge difference. So the gentleman who was talking is a great gentleman. He said this, that soul food has killed more Black people here in the United States than anybody else has. Probably it's time to begin to really sit down again and look at the soul food that we eat. There's a reason why we had that when it was convenient, but is it convenient today? Is it contributing to a whole lot of our deaths where we have obesity and diabetes in our community? Because putting those two factors together, a whole lot of complications are coming out of this. Now, one of the things that saved us, and we alluded to this, especially those of the African continent with COVID, and we all know, we understand that number now, is vitamin D. New studies are beginning to show that women with low vitamin D less than 30 into pregnancy have a higher risk of developing diabetes in pregnancy. So should we begin to now say, you know what, for all the OBGYNs out there or everybody else who are out there, please, if someone is planning to get pregnant, outside of putting them on prenatal vitamins, ensure that the vitamin level D level is higher and above 30 or 60, because the top range is about 100, so that the risk of pre-diabetes and even the complication for their children is reduced. These are issues we must begin to talk about. These are issues we must begin to engage.
Excellent.
Well,
Excellent.
Nelson, that's why that's my whole point, that the whole concept of peripartum starts with the idea of becoming pregnant and what is my current health condition, what is my current healthcare status prior to become pregnant. We should, patternize our blood pressure. We should know, as you alluded to, what elements as your vitamin D level is like. We should look at our vaccination rates for common illnesses. We should turn and look at our own family history, the incidence of hypertensive disease and diabetes in our own families, and to those close to us, as in your own mother, because we know these are all probably genetically related conditions that could influence your healthcare going forward. The other thing is, oftentimes these pregnancies are not planned. So early intervention with early risk assessment needs to occur. And for the patients themselves, one of the things that I advocate is to get to know your healthcare provider. Have a sense as to when you speak, do they listen? Okay, because common things are common, but uncommon things are just that. The indicators are often very subtle. And oftentimes those subtle indicators are repeated, but attention is not paid. Okay, so, and the little things that we take for granted, the pregnant mother who comes in and say, I get pain in my right upper quadrant every time I eat or I drink or I consume certain things. And we attribute it to just elements in the GI tract. May not be the case. These subtle complaints needs to be not simply stated, but revisited. And I think whenever we find subtle signs of change and change that are consistent, albeit subtle, then we take it back and see, could these be indications of certain things to come?
Right. Dr. Garrison, thanks, Dr. Patrick. Dr. Garrison's had his hand up for a while.
I guess I've broken my pledge to be quiet today. So, I think just simply the fact that we've got 10 different physicians on the line and Dr. Anderson talking, this pregnancy is so multifactorial. And each one of us has an aspect of it that in our practice that would pertain to the pregnancy. The vitamin D, I mean, that's nutrition. That's what Dr. Fredericks is all about. I mean, and one thing that we know about obesity is it increases the immune system. And so you're in a hyperimmune state. And what we found out in COVID is that the COVID causes the increase of the immune system even more so. And that's why obese people were the predominant number of people that succumbed and died from the disease. One of the things that I heard you talked about was not necessarily access to care, but the changing patterns of care and the fragmentation of care. Just a simple, my own personal story, when our child was being delivered, my wife said, I only want my OBGYN. I said, well, there's 30 different OBGYNs, African-American OBGYNs, who are more than capable to do the delivery. She said, yes, that's true, but I only want my OBGYN. And you talked about how somebody may get their prenatal care one place and then the delivery another place. Could you talk about the impact of our new corporate style medicine where you may go to one OBGYN, but there's 12 on staff and you don't know who's delivering your baby? Could you talk about the impact on that and how it may affect the African-American community?
I mean, in at least in our institution, what we try to do is we try to have a system where the patients visit what we call a pregnancy or a centered pregnancy program, where from time to time, there are different educational programs that are presented by different providers. So at least when they come in, the reality may be that it may not be your specific OBGYN for whatever reason, travel, cases in other places. A colleague may be the one doing the delivery. But at least what we try to implement is a certain standard that when you come in, the following procedural elements are in play. All right, we follow the same standards of listening. We follow the same standards of evaluation. We follow the same standards as it pertains to identifying certain disease entities. And we follow the same standards as to the level of providership that's available in the institutions. So for example, one of the things that I can honestly say we're most proud of at Newark Beth and throughout the Barnabas system actually, is the acumen and the number of high-risk pregnancy physicians. And their areas of focus are vast. There are some who specialize in thromboembolic diseases. There are some who specializes in metabolic conditions, as in diabetes. And there are some who specialize in management of other endocrinopathies, such as thyroid disease during pregnancy. And all these individuals are linked and are accessed when patients come in. The bottom line is, when these patients comes in, there is a set of standards that are in play that identify potential pitfalls. We go through many different things. And it includes training the young doctors, the whole issue of simulator training, right? One of the big issue in maternal mortality is postpartum hemorrhage, right? There are standards as to how to evaluate patients with respect to postpartum hemorrhage, down to not just counting the number of lap pads, which is, these pieces of cloth that we use to absorb blood during delivery, but down to weighing them before they come in a specific packs. They weighed before the delivery process starts, and they weigh during and after, and using weight as opposed to a visual perception as to blood loss. That way, we decrease the variance in how we perceive not just acute blood loss, but the amount of blood loss. That way we don't turn around and all of a sudden the patient is hypertensive and in shock, and we realize that they've hemorrhaged right in front of our eyes. Yeah. So there are certain standards, and these developments are continuing. They're visited and revisited and assessed, and we go back and look at the data as to when they were implemented during certain condition to make sure that the accuracy is reproducible.
Yeah, but Patrick, let me just guide you in another direction. I understand at your center, this is what you do, but for the patient out there, let's talk about the patient and what they can do and how they can monitor themselves or whatever. So some signs and symptoms of medical emergencies that, patients don't realize that they're having an emergency. I'm talking about things like chest pain or heart racing or persistent pain in the lower abdomen. These are some of the things that I'd like to relate, because not every system out there, and most systems out there, I should say, aren't like your system. And that may be the problem. We need to connect to the patient and have them have, a better connection as to when you're in trouble and who to see and how to proceed.
Right. And with this, I agree. Every pregnant woman needs to be in contact with a pregnancy-related provider, whether it's a physician, a midwife, a doula. Okay, and that's the key here when we talk about a pregnancy-centered program. So through a centering of pregnancy program, what patients get is educational information, things to look for, things to think about when they're different. So how to count the number of movements for the baby, how to recognize chest pain, how to evaluate shortness of breath, how to take care of their young infant. When do you recognize dehydration in a young infant? Is the Pampers wet? Is it not? How to breastfeed. All these elements goes into, and more, goes into centering of pregnancy. Now, a big part of that, it's no use teaching someone what to expect if when they need help, they can't gain access, or they cannot access or get connected to the mainframe being the providers who are either going to take care of you in the acute setting or your provider who knows you on the day-to-day. And one of the endeavors that are put out there is everyone's got a smartphone. And there are apps that are put on these smartphones that enables patients to identify and assess certain symptoms, right? There are certain algorithms. And then a key piece of it is when they make a phone call, they don't go through a call center that escalates them to another person who then send them to another person. They get directly connected to a labor and delivery suite or an obstetrical service that with some provider who can get on the phone and said, these symptoms are concerning, you need to come in. And not only do they need to come in, so now they can call the emergency department and say, Mrs. X is on her way. Please put her on their way list. And I have the following person who you should call. This is the number. They'll come down, evaluate this person, and get them to the location where they can appropriately be evaluated.
Excellent, excellent. All righty.
Yeah, I have a comment to make, if you don't mind.
Yeah, definitely.
Sure. I think a lot of what we're talking about is care coordination, right? Making sure the episode of care from the pregnancy to delivery, there's communication. And I think, having protocols in place is very important, but it's also how the patient learns about it. You know, the physician can have the one-on-one engagement in the office. There could be mid-level providers, and there can also be online information that Patrick was alluding to, or whether it's in an app form. And I think if we can't coordinate the care of the patient, we fail. And I think it's important to also recognize that as attending physicians, we're not going to be able to see that patient all the time, or not necessarily be able to answer their call. And I do feel that having mid-level providers, folks, either the nurse practitioner, physician's assistant, or other nursing staff who are well-versed on what has to be done or what the patient needs to be educated is very important. And I think, you know, that goes along with physician leadership, understanding that we're not going to be able to answer every phone call for that patient, but having a process in place where we've taught and educated mid-level providers that can take some of the high volume phone calls, the troubleshoot phone calls that we may not answer, and delivering in a way that the patient can actually use that information.
Excellent, excellent.
Yeah,
But
and
thank
you know,
I
just
mean,
as
I
Dr.
must say,
Lee says,
Dr. James, thank you
Go
so
ahead,
much
go
for
ahead,
bringing
Dr.
that up.
Aluya, and then Dr. Anderson. Go ahead.
Right. I mean, Dr. James, thank you for bringing that up so much.
Yeah.
I mean, first and foremost, we're very few. We have very few Black providers, and we have very few who are in the specialty that Dr. Patrick Anderson is. So we really do need those mid-level contact to help. And like you said, you know, nurse practitioners, they have a huge, huge void to fill. And we must begin to understand and embrace them as well. And know that they're not competitors, but they're happy to complement what we do. Understanding that will help, especially in our community. Thank you so much.
Yeah, Dr.
and I just
Anderson.
want to make two comments with respect to that. The first one is, you know, oftentimes patients like to go to places where the amenities are great, folks are gentle, but what we do know, especially if you're from a high-risk community, you have known high-risk factors, is outcomes are directly related to high-volume specialists, people who see a lot, do a lot, and knows how to do much, okay? And the other piece of it that Dr. Aluya alluded to was, one of the things that we try to do is, you know, you can be part of the process, right? And whenever there's a problem, if you go back to the previous state and see how you can influence the previous state, then you can make some differences. One of the things I know I do is we have these, for example, nurse practitioner programs that are often looking for providers who can provide clerkships for their nurse practitioner students. And that's one area that I know I participate in. And I had an experience recently with one nurse practitioner student in my office where, while I was focusing on the disease element, this young sister took it another level. She focused on the social aspect that was preventing this particular patient from access. And it made me realize that the important factor of the day was not even the disease issue. It was fairly well controlled. It was that which was influencing the compliance. So, you know, physician extenders, you know, high volume providers in institution that does high volume work, not just in terms of numbers, but in terms of the acuity of the conditions, I think makes a difference.
Yeah. Excellent, excellent. I think this is a topic that will come up again and again because it's so important. And I don't think we have the answers yet. You know, that's the problem. We're a modern society that has a problem that we haven't solved, and it needs to be solved from a community perspective as well as a physician's perspective. So we're going to keep digging into this until we can improve these numbers, because I think it's just that. And, I got another question. And this question is a basic question about weight. And I think that we have talked about weight is something that crosses borders as far as health is concerned. That she's overweight, you know, and she calls herself obese, stating that her joints are suffering because of it. And she wants to know if losing weight will, number one, improve her joint status, and number two, help prevent her from becoming someone who needs knee replacements. Dr. Lee, can you start us off with this?
Yes, I heard most of what you said. I believe the general theme here was will losing weight help with taking pressure off the joints and improve joint health and prevent further degenerative changes.
Mm-hmm.
And I think that's the case. So, you know, if you just take a simple math problem and you look at a patient who's obese and say they're 300 pounds, and when they come in the office and they say, oh, my joints hurt, and we look at them globally and realize they have high blood pressure, diabetes, and maybe the diet isn't so great. A lot of times we think, okay, you know, there is a lifestyle change, which is very difficult. And then there's the immediate, like, oh, my knee hurts. And I think they come into, you know, the orthopedic office with the knee pain, and we try to educate and say, no, I think this problem is probably related to the weight and lifestyle. But if you look at math, if you walk up and down stairs, that's 3 to 5 times your body weight on the joint. So if you're 300 pounds, that's up to 1,500 pounds of force on your knee, okay, on your hip or on the joints involved. So if you lose 100 pounds, that's 300 to 500 pounds of force less across the joint. So to answer the question, yes, oftentimes, you know, if I correspond with Dr. Fredericks, for instance, and I say, you know, yes, you have arthritis, but no surgery needed, maybe medication and an injection to help you walk around. But the real problem is your weight, your lifestyle, and your diet. And oftentimes I call Dr. Fredericks on the phone and say, I have somebody for you. I don't think they're surgical. They've come to me because their knee hurts, but let me refer them to you so you can work on the diet, lifestyle, and the other things that are factors here.
Mm-hmm. Dr. Fredericks, so let's lead it right into you.
Okay.
Then. Tell us some of the areas or some of the techniques that people can use that would, you know, because what I'm talking about is techniques that would be for our community, for the African American and Black community. What techniques work for them? Can you give some insight here?
I think it's not just Black communities. I think obesity is a disease that affects all communities, right? And the more you get heavier, you start to get sicker. And when a person gets sick from their weight, you need to do something about it. Trying to lose weight is a difficult thing because the body itself does not really want to lose weight, because weight is the way the body is getting its energy source and trying to protect that. So when you're starting to get heavier and you start to lose weight, the body will then secrete hormones to try to get that weight back up, okay? Now it gets to the point where you're starting to get disease from that. Now we have to do something that's gonna bring that weight down more rapidly, all right, to get rid of those diseases. That's when you get morbidly obese. And that's obesity is a situation where you're putting on excess weight. And when excess weight starts to cause health-related issues, we need to do something to help it come down much faster. And so the surgical interventions
We have a poor connection
that you can use to help lower that and get the person better, right? And so those are the type of things we tend to do. So in order to do surgery, we need to recognize how significant heavy a person may be, okay? And so we do something called the BMI, right? So for BMI, which takes your weight and your height, put it in an equation, and we get a particular number that tells us how heavy a person really is. If a person has a BMI of 35 and has comorbid conditions, those conditions that are affected by the weight, hypertension, the diabetes, the sleep apnea, we need to get that weight off. So a surgical intervention can bring that weight down into a manageable point and tends to get rid of those conditions. In fact, a lot of my endocrinologist friends send me their patients to get off their insulin, to get off their medications because they lose that weight. Mm-hmm. And so that's something that we tend to do. And when we're doing the surgery, there are different types of surgical interventions we tend to do. There's some that are called restricted procedures solely. There's some that are most restrictive and malabsorptive, meaning they're cutting down the amount of calories you're taking in. And so those are the type of things, those are the type of surgeries I do. The most popular surgery is a surgery called the sleeve gastrectomy. And that's where I cut and I remove 80% of the stomach. You're saying, wow, that's a big issue. But it helps. It takes away some of those hormones that cause a person to get hungry. It cuts down on the amount of volume of person to take in. And so patients really get that
Okay.
weight off and it becomes more manageable. If the weight is even higher than that, like do something called a gastric bypass. Yeah, and that's even more significant because that's going to get a person weight down much faster. And so those are the surgical interventions we do. But now we can, if a person's BMI is getting heavy, but they're still not to the point where they need surgical intervention, the medical management we can now do to help control one's appetite and get them to eat better. All these different things that I do.
Okay. I think we have a
management. It's ultimately.
All right, we have a poor connection there.
Oh,
but we heard most of it. But yeah,
but I want to leap it back to you because it's all about nutrition and all the different things that I do, the surgeries that I do, the medical management I do. It's all as a tool to get a person to eat better.
Yeah. It is so important. So important. I agree 110%. The thing of it is that I think, and all of us will agree, is that that our weight, number one, has a significant effect on our health in so many ways. And I think each and every one of us as a physician has to, engage with patients that are that have this problem. And number two, try to find the best way to treat that medical problem that they're coming to see us for. So I wanted to go into what we need to do for, or how should preparing, maybe I should put it this way, preparing for surgery. All righty, we're talking about a GYN, we're talking about, weight loss, but the big, one of the significant areas of this is preparing for surgery as well. And there was a question that came in, and someone going to surgery and wanted to know, how can I prepare for surgery such that I can increase my chances of doing well during that surgery and post-surgery and recovery? What can I do to prepare for myself? Dr. Clark, you haven't said a thing all day, and let's bring you in, and then we can get some of the other physicians to weigh in on this. I know from my perspective, I definitely have something to say about it. But Dr. Clark, can you lead us into this?
Sure. So I think the number one thing I tell patients, if you smoke, immediately stop smoking. I think that's one of the most important things that can help with the overall perioperative period. It's if you have comorbidities, so hypertension, diabetes, hypercholesterolism, you want to have those things under control. I think it's best to have all of your chronic conditions at least at a baseline under control, because that's going to help facilitate your recovery. And I think the other thing is to mentally prepare yourself, depending on what operation and what the disease process is, to have an understanding of why you're having the procedure, what exactly it is and what it entails and what to expect. I think if you have an understanding, it's not a surprise when things happen, and you're able to navigate that process a lot more smoothly.
Now, Dr. Garrison, I know you're a surgeon as well. Is there some way that you approach your patient that sets them at ease, or that you can assure that they're going to have a better outcome?
I believe, like what Dr. Clark was saying, that a positive attitude goes a long way to surgery. I've had several patients over my course of practice who on the day of surgery say, I had a dream last night and I'm going to die. And that's an immediate thing to say, okay, well, we're going to postpone you for another week. Not a good thing. So I think whatever it takes to have a positive attitude, sometimes, medicine way it's practiced in our culture is we practice disease, we don't practice prevention. And it was said that the important thing is the respiratory component and also exercise. We don't want you to go out and run a marathon, but I would say to start to do something, walk around the block, go to the track, just to do a little something so we can get that pulmonary status up and running. Comorbidities need to be addressed. And also, when a patient goes to their physician or their surgeon, I think they should be really honest and say what they're afraid of. We should also ask them to assume that there's some fear there and say, are you afraid? What's going on? And give them some realistic expectation of what can happen. A lot of patients come in here and expect all of their spider veins to disappear. And I have to be realistic. Dr. Fredericks has to be realistic about, hey, listen, you may lose some weight, but you're not going to be, you're not going to be Kim Kardashian. Dr. Lee has to let people know that he can fix their hip or their knee, but they're not going to be able to play in the NFL again or things like that. So I think setting realistic expectations for the patients is an important thing, as well as addressing their fears and anxieties.
Yeah. Dr. Lee, I have a question. Dr. Atherley, one more. Dr. Lee, I have a question. I know you have something to say as well, but when would a patient present to you that you say, I can't do your surgery right now, or this is why I can't do the surgery, or you get to the OR and surgery is canceled? Does that happen, and how does that happen, and how do you get through that?
Yeah, I'll give you an example of a canceled surgery, uncontrolled hypertension. So what happens, I had a gentleman who was having a shoulder procedure. We had him, he went through the pre-admission testing. We get him into the operating room. The anesthesiologist puts him to sleep. We're about to prep and drape, and the blood pressure was like 250 over 120. And we aborted because, that person is at risk for stroke. And so, what we did is we aborted this procedure, we canceled it, and then we sent that patient to the emergency room to get looked at. And so I think part of what we also have to distinguish from this discussion is we have elective surgery, which means planned surgery. It means the patient and the doctor agree that this surgery that isn't an emergency is going to be on such and such date. And we're going to make sure before the surgery that 30 days before or so, you have your blood work together. You have your medical doctor has signed off on you having surgery. You have agreed that you understand the risk of surgery, the benefits, why we're doing it, why we wouldn't do it, and have a realistic expectation, like Dr. Garrison was saying. Dr. Anderson and Dr. Clark probably have a different subset of patients because they're cancer patients, right? There may not be ideal circumstances. These people may be on chemotherapy. They may be anemic. They may have a different time frame at which they can have surgery, and how they're educated is going to be different than somebody who's maybe a relatively healthy person that has something that can be addressed electively. Socially, I also think it's very important in preparing for the surgery is, what is your post-op plan? Do you have somebody at home who's going to help take care of you? Do you need to take time off from work? I can tell you my practice, what we do all the time, disability paperwork. People are all about that. They have their secondary disability. Maybe they have to, they have an insurance like a Geico, and they say, Doc, my Geico is going to kick in. Can you make sure that you give me my dates, and I'm going to tell my supervisor that I'm going to be out? That is a mental health factor, because people, when they're out for a period of time, revenue goes down. They may not bring money in. So those are things that really also have to be addressed in coupling with the medical factors as well. And I think play an important role. For me, if I have somebody with an elective surgery, I don't want them to say, oh, they're going to miss a graduation, or, you have a vacation, you want to go on all that stuff, get it done. Because when you have surgery, we want you to heal. We want you to focus on healing. And if you have all these other circumstances that aren't together, I truly believe that has an effect on the outcome.
Dr. Athol, you were really ready to say something, Dr. Athol.
Yes, I was going to say something which alludes to a part of what Dr. Lee said, and that is when patients are scheduled for surgery, or when surgery is recommended, it is not only what we can do to prepare them for the surgery, but the first step of preparation is assessing the risk for surgery. So we can then see that there's an appropriate risk-benefit ratio. And I'm very often called upon to consult on the patients and to clear them for surgery. And many times from my particular specialty, I go through the so-called criteria. I look at a specific subset of criteria and then can assess some degree of accuracy the chance of the patient having an adverse effect after surgery or during the surgery. I look at what's called the revised Lee criteria. I go through the gamut of, has a patient had a stroke? Does the patient have uncontrolled high blood pressure, diabetes that requires insulin, et cetera, et cetera. There are a number of characteristics I look for. And then I can inform the surgeon that the patient is at low risk, moderate risk, or high cardiac risk for surgery. I mean, my surgical colleagues always remind me they can cut and stitch without the problem. The problem may be the anesthesia and the patient probably waking up and having a good outcome afterwards. It's not just cutting, not just the surgery, but it's for anesthesia and for proper recovery. So I do go through this specific criteria I go through and can determine and inform them in my consultation as to what I consider the risk to be. Then they can assess whether the risk is appropriate, whether it's elective, cosmetic surgery is really that necessary, seeing that they've had 4 heart attacks and strokes, et cetera, whether it's really necessary, et cetera. So I think an important aspect pre-surgery is assessing the risk with the surgery.
Right.
Yeah. Omar, if I might say something,
Yeah,
you know,
please.
and Kevin and I, you know, side on this all the time because there is oftentimes the perception of having surgery is a procedure will be done, an intervention occur, and they will be better. But better oftentimes does not equate to different. Sometimes a lot of what, you know, many of us surgeons do, and, you know, for Kevin and I, we're not often improving quality of life, but we're trying to change a disease state. And oftentimes there are certain physiologic function that has to be sacrificed. And this may relate to anostomy, this may relate to living with
Patrick, you got to explain what you're talking about. Ostomy. Come on, brother, break it down.
Right. Now, this may affect their ability to engage in certainly bodily function as to how do you control your bowel movements, how do you control your urinary function, what is your sexual function going to be like, as opposed to just your ability. And not to diminish what Dr. Lee does, I say just because he's done some things to me that has totally improved my quality of life, but how does it improve, not just how it improves your ability to move and lift and walk. So your quality, not just your quality of life changes, but your life function changes, period. So, and that comes with a certain degree of acceptance, right? And there's some mental health evaluation and counseling and treatment which has to occur. So oftentimes, you know, we rely on Dr. Salam to intervene, right? And help them distinguish how they will function, knowing mentally that they're going to be different and how they're going to be proactive in adapting to these changes.
You know, Dr. Salam, we're going to bring you in right now, brother. Dr. Garrison earlier was talking about the mental state of the patient going into surgery was so important. And now Dr. Anderson's talking about, you know, what result will you have, you know, at the end, and will you be satisfied with that result? Because in treating cancer, like Dr. Anderson and Dr. Clark does, it may not be that you're going to feel better at the end or you're going to change life, but it may be life-changing, life prolonging. So can you give us some understanding from your perspective? And then after that,
can I just ask one question real quick, Dr. Salam?
Sure.
In addition to what you're going to address, can you help me in terms of patient says, Doc, I'm really scared of surgery. How would Dr. Salam help me reinforce, you know, that everything would be all right? What techniques would he use to treat assess such a patient?
Well, number one, let me apologize for joining the webinar so late. I'm Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist, and I'm delighted to be here. I practice in the city of Philadelphia. So in terms of the mental health aspects of impending surgery, I know Dr. Garrison could speak to this because one of the surgical procedures, I believe Dr. Garrison and Dr. Fredericks, they perform bariatric surgery, and that requires a pre-op psychological assessment to assess cognitive ability, so the ability to construct ideas and problem solve, and to assess whether the patient could the person having surgery could follow the regimen, the post-op regimen, and they could understand the risks, the benefits, the rewards of the surgery, the complications of the surgery, and the changes in their lifestyle, and whether they be dietary changes, changes in body image, and the like. So you want to have this conversation pre-op, and there are probably rare circumstances where the surgeons may not actually proceed, particularly if, let's say, someone has an underlying mental illness or mental health problem that has not been addressed, and it alters their ability to perceive things, and it could affect their body image and how they expect to look. If someone is manic, they may have inflated expectations of the results of this surgery and the like. Now, to address Dr. Court's question, someone entering into surgery and they're having anxiety, and it may interfere with their ability to actually give consent. I think the antidote and the remedy to that is a clear conversation about the procedure, about the risks, the benefits, how life will change, and the potential drawbacks. Not hiding behind medical jargon, just being clear and having a conversation with a human being as if they have no medical training. We have an advantage if, let's say, it happens to be a person of color. They may actually trust you more. They may actually feel as if you're working towards their best interest, and they may be less guarded and or paranoid going into the procedure, and feel a sense of relief, like this is someone from my village, from my community, who's going to take care of me, keep me safe. And prior to doing all that, they're going to explain things to me at a level where I can understand. Minimizing uncertainty, which really diminishes anxiety. So again, the conversation you would have with a layperson, really explaining things at a level that they could digest it.
Excellent, excellent. Dr. Daniels, you just came in, and welcome, brother. What we are talking about a topic which is playing in your field, as far as how do we get people or patients to be comfortable such that they come into surgery knowing that they are going to be taken care of well. And is that a major factor as far as their healing and getting through the surgery? We've even approached certain aspects as when we would cancel a surgery from different specialties of surgery. And how do we approach? Go ahead.
Can I ask him one question also for Dr. Daniels? Because frequently I'm faced with patients who say, well, I'm not having no back surgery because I wouldn't be able to walk. I have known of X, Y, and Z people who have had back surgery and they can't walk. Yeah. And there's this fear. Well, what's going to happen?
That's a big thing. Yeah. Brother, can you enlighten us?
Help us.
Yeah. So here, this is what I'll do. Generally speaking, we work for you, right? Every doctor, every nurse, every medical assistant, the anesthesiologist, the MRI tech, we get paid by accessing benefits that you are paying into, right? And it's, some people, some doctors' styles are to command to you what you needs to be done and tell you what to do. And that's because there's an overwhelming amount of knowledge and experience that goes into the decisions they make. And doctors are really, really good at making these decisions. But never lose sight of the fact that we work for you. And so there's a key component in medical ethics. It's called autonomy, right? And it means that patients should be in control to make the decisions that they think are best for them. In order for that to happen, there's this process of informed consent. And theoretically, what that means is we are going to take all of our knowledge and give it to you so that you can then make decisions independent for yourself based upon your lifestyle and what you want and what you expect. But when you're dealing with the fear of surgery, the trepidation of surgery, these emotions come into play, and sometimes it takes work for that to happen. And when you're trying to do that in an organized medicine setting where you might only have 15, 20 minutes to see a patient, especially if you're trying to do it right before surgery, a lot gets lost in translation. What I would say is before the day of surgery, you should have a clear understanding of what you're getting into. All your questions should be answered, and you should walk away from that interaction with your surgeon that's leading you to that point, feeling like this person cares for you, they love you, and they're going to do everything in their power to make sure you're okay. Even though we can't control everything, risks occur and they're out of our control when they happen. We do things to mitigate them, but if anyone could control risk completely, no one would ever have a complication, right? So it's baked into the technology. There are limits to what we can do for your disease process. And our thoughts are, as long as we're honest with you with that, and you can take that stuff into consideration, then you can make a really good decision for yourself. The second question, and I do believe it's easier to do that with doctors, not because our skin tones are the same as yours, because we have the same experiences. Don't think that we're not receiving the same type of, right now I'm in my office in Spring Lake, New Jersey, right? I got an apartment around the corner from here. When I first moved to Spring Lake, New Jersey, I got pulled over 5 times in the first 2 months. I had to tell them like, yo, put out an APB or something and tell them to stop pulling me over. I'm the only pediatric neurosurgeon in Ocean and Monmouth County at any given time, right? And you keep pulling me over, something's going to happen. So we have the same life experiences that we all do in this country, in this society. And as a result of that, it's easier for us to understand where your trepidation comes from, where your fears come from. And I think it's easier for us to be more compassionate in the setting when you have a patient who tells you something like, I'm not getting back surgery, because everybody I know who got back surgery, they don't do well. People telling me not to get back surgery. I can't tell you the number of times that I've heard that. So transitioning into that question, there is a problem with surgeons doing too much surgery. Some surgeons have the attitude that, well, listen, if they're in my office and I'm going to spend 30 minutes with them and they have pathology that might be treated with surgery, I'm going to offer them surgery. The problem is, what should occur is all of your different alternatives should be presented to you, the non-surgical and the surgical, and your pathology should be explained to you in a way that you decide whether you want surgery at that time or not. Sometimes surgery is the only way to go, and there's no guarantee that surgery is going to make you better. But sometimes there are other approaches. And we know this, and specifically in spine surgery, we know this, that because of the way the incentives are set up, some surgeons do more surgery than necessary. I can't tell you the number of patients that have come to me after they've had surgery from a spine surgeon, and they've had this huge fusion, and all they needed was a decompression. But surgeons get paid 10 times more for fusions. It's a problem. So too many people are having fusions, right? So, and I tell people this all the time, we are going in to rearrange your anatomy in a manner that we think will be beneficial for you. But if I go in and I give you a fusion and you don't need a fusion, 100% of the time you're going to be worse. If I do spine surgery on you, and the spine surgery and that's not causing your pain, when I make an incision, when I take out your disc, when I put screws and rods in your back, when I cause that additional trauma, if we're not treating the thing that's causing your pain, you're going to have additional pain because you have additional injury, right? So my answer to you was like, one, you should be with somebody that's willing to get you up to speed, that's willing to educate you on why your pain exists. And once you leave that conversation, you should try to be able to go and confirm that for yourself, maybe even get a second opinion. And at the end of the day, if that person's not treating you like their loved one or their family, if you don't feel like that connection's there, be really, really wary. Because ultimately, all of us on this panel, as much as we might try, we're never going to be able to give you the experience that we have. So you have to trust us. I was having a conversation with these guys who were in the business of developing business for doctors. And we were talking about getting patients and marketing get patients. And they had this bravado about them. Like, yeah, we can get you all of these patients, so you need to listen to us. And I had to stop them and tell them, I'm like, listen, if I put you in a room and expect you to do what I do on a patient, 100% of the time you will kill that patient. 100% of the time you will, right? And I do this every day. That's how complicated it is, for us to do some of the things we do. And although we should be trying to give you as much knowledge as possible, you really need to be with the type of physicians that you trust and that you know that are going to care about you as a human being, not just as a potential surgery or a potential case.
Excellent, brother. Excellent.
Yeah, I
Dr.
think-
Garrison, I'm going to ask Dr. Garrison to speak, and this is what we're going to do because we're running over from, we didn't take our break. I want to reintroduce the physicians real quick after you, Dr. Garrison. But before, go ahead, and I'm just stating that.
You know, once again, Dr. Salam has stolen my thunder. Welcome. And Dr. Daniels, good to see you again. You know, you're both right on point, the things I say. One of the things, patients don't know what they don't know. Trust is earned. And we have to bend over backwards at times. We got to do a little bit more. We have to understand what the problems and the questions are. And even though the patients don't ask them, we need to present those to them and just tell them, this is what you can expect afterwards. They don't know to ask it. They don't know, you know, well, they don't know how to say, well, my sex life be affected. They don't know how to say, well, my eating habits or my bowel habits. They don't know that, but we do know what the potential outcomes are. So we have to utilize the art of medicine. You know, Dr. Daniels was talking about they have to trust us. There are things that we know to do to earn that trust. You know, sometimes we just can't be in a rush. We got 20 patients, we want to see them all, we want to get it done. We got pressures that everybody else has and our colleagues from a different persuasion have, but we also have the pressure of these people look at us and there's a level of distrust that has been generated at some point in time. And at the same time, they want to trust us. So sit down, have a conversation with them, ask about their family, how they're doing. Ask them to bring their family to the interview. A lot of times there are older patients, there is something about them that they don't want to look stupid or dumb. So they'll nod in agreement and yes, sir, yes, sir, yes, sir. And then they'll go, can you call my daughter, please, and speak to her? So a lot of times we have to assume certain things and we have to go above and beyond with our patients to get them to feel comfortable and trust and to educate them. You know, I think we all want to do a good job. We all love well, there's some family members I have I'd rather not talk about, but for the most part, they deserve our love and care too, as physicians. And I think we got to establish trust and just do a little bit more for them.
All right, this is what we're going to do because this conversation is so great. I know Dr. Aluya and Dr. Salam both have your hands raised. Let me do this. I'm going to read something from, it's called Advice from a Patient. Then we are going to take a moment break, and then I'm coming back with Dr. Salam and Dr. Aluya will continue. Hold your thought, brothers. All right, Advice from a Patient. This is something that I was sent, and I think Dr. Aluya actually put this out, and I'm not sure who the author is, and whoever the author is, I appreciate you putting this out there. It's called Advice from a Patient. This may be a normal day at work for you, but it's a big day in my life. The look on your face and the tone of your voice can change my entire view of the world. Remember, I'm not usually this needy or scared. I am here because I trust you. Help me stay confident. I may look like I'm out of it, but I can hear your conversation. I'm not used to being naked around strangers. Keep that in mind. I'm impatient because I want to get the heck out of here. Nothing personal. I don't speak your language well. You're going to do what to my what? I may only be here for a few days or hours or whatever, but I'll remember you for the rest of my life. Your patience needs your patience. All righty, so we're going to take a break and just for a minute, and I will say the most important thing is that please do not change any aspect of your medical care until you consult your physician. That's the most important thing that I could say today, and please remember. Understand that we're a group of physicians that are here. to educate the African American and Black community. And also, I would like to thank OBHealthy for allowing us to bring this platform to you. Our webinars, if you want to check out our old webinars, go to obhealthy.com, scroll to the bottom of the homepage and hit the YouTube sign. You will be able to view all of our past webinars with no problem. Okay. Did I miss anything? No, I don't think I did, but if I did, we will catch up with it. We're going to introduce each of the physicians again. Dr. Aluya, please, you're on mute. Let's start off.
Yeah, Nelson Aluya, medical advocate, again, work with some of these great minds, and a pleasure to be here every second Saturday of the month. And it's a pleasure to, be given access to speak to you and share my ideas and thoughts. Thank you.
Thank you. Dr. Salam.
Good afternoon, everyone. Dr. Kareem Salam, board certified adult and child and adolescent psychiatrist. And I'd like to quickly add to one of the missions of this webinar. And we as African-American male physicians, we want to inspire those coming behind us to pursue careers in medicine and symbolize the possibilities. If you apply yourself and take advantage of opportunities available to you, this is very possible.
All right. Dr. Atherley, please.
My name is Trevor Atherley. I'm a board certified cardiologist. I practice interventional cardiology, predominantly at Newark Beth Israel Medical Center. And of course, one of my pet interests is in teaching of the young cardiologists that we train.
All right.
Thank you.
Thank you. Dr. Anderson.
Yeah, my name is Patrick Henderson. I'm a board certified obstetrician gynecologist and gynecologic oncologist. Practice out at Newark Beth Israel. I'm just happy to be here second Saturday of every month.
All right, Dr. Garrison, please.
Hi, my name is Dr. Jordan Garrison. I'm a board certified general vascular and bariatric surgeon, presently practicing with disease of veins in Hackensack, New Jersey. And why I have the floor for a second, I have to ask Dr. Salam if he can address this a little later on. It is the month of Ramadan. Could you address the psychological and the eating habits that need to be emphasized during this month? Thank you very much.
Excellent. Dr. Court.
Good afternoon, Dr. James Court. I wouldn't miss this for the world. I've learned so much from listening to my esteemed colleagues. Keep it up, doctors.
All right.
I practice in East Orange, New Jersey.
Excellent. Dr. James Lee.
Dr. James Lee Jr., good afternoon. I'm a second generation board certified orthopedic surgeon. Glad to be here.
All righty. Dr. Kevin Clark.
Good afternoon, Dr. Kevin Clark, surgical oncologist. I work out of Newark Beth Israel with most of these distinguished gentlemen.
All right. Dr. Lawrence Daniels.
Thank you, Dr. Lawrence Daniels, adult pediatric neurosurgeon. I'm medical director of pediatric neurosurgery at Jersey Shore University Medical Center.
Excellent. Dr. Fredericks.
Linda, I thought you forgot me. I'm Dr. Dwayne Curtis. I'm a bariatric surgeon. I specifically do obesity medicine in South Orange and now in Bergen County.
Excellent, excellent. And I'm Dr. Omar Bey, pulmonary critical care physician and with a subspecialty in nutrition, and so pleased to be here. All right, Dr. Salam, can you start off with your question and then we'll go to Dr. Aluya.
Sure. So we were talking about surgical complications and some of the awkward topics of conversation, whether it be, will I be left with incontinence? Will I be able to walk? Will my sexual function be compromised? And I think in the essay that Dr. Bey read, there was a mention of a fear of appearing stupid or lacking knowledge. And so to ease the burden on the people we serve, these awkward questions, we may want to reframe them and say, perhaps a concern I might have if I were having this procedure is how it would affect my ability to walk, how it would affect my ability to have intimate relations with my partner. Will it leave me with, will I have accidents of the bowel and the bladder and things like that? And that way you relieve the patient of the burden of one, having the conversation or introducing it. And it could be very liberating. And they could say, you know what, that was on my mind, but I just didn't know how to bring it up. Okay. So for example, when I'm interviewing young people about substance use, which they tend to underreport, I'll ask the question as if I'm assuming that they use nicotine, they use cannabis, they use alcohol. So how much weed do you smoke? And then once in a while, a young person will say, well, I don't smoke any. But those who do, I relieve them of the burden of the admission, the confession. And that could not only could that ease the interaction, but it could, solidify rapport and trust between the physician and the patient. Finally, to Dr. Anderson's point, after I have one challenge I have, or one task that I have, is I prescribe medication that affects the brains of other people's children. And so when I have these conversations with them, I remind them that if you don't give me informed consent, and I cannot prescribe this medication. So at the end of the day, the decision is yours, but this is a tool I can use to help. And then finally, I know I said finally already, but to address what Dr. Garrison raised, we're practicing Muslims. It is the Muslim holy month of Ramadan. And during the Muslim holy month of Ramadan, you can ingest nothing by mouth between sunup and sundown. So before the sun rises and after the sun sets, you could eat and drink, but during the daylight hours, you cannot. So for example, if you take oral medication, and if you must take oral medication, then technically you can't really fast. And then there's some medical conditions where you really should not fast, like diabetes, where you have wild swings in blood sugar, and you may have to address an emergency in terms of a low blood sugar known as hypoglycemia by ingesting something through the mouth. Most folks are not in an environment where they can, take IV glucose or something like that. So in anticipation of Ramadan, it could be anxiety provoking because 11 months of the year, we're eating and drinking and going on about our lives. So it should involve preparation. I'm a big fan of caffeine and caffeinated beverages, so you might want to wean yourself off in anticipation of the fast. And also, when you're fasting, you should really minimize stress. You shouldn't be in toxic environments, and you should watch what you're ingesting through your mind, through your senses. So you shouldn't be around toxic people. You shouldn't be viewing explicit material and things of the like. But it's a beautifully rewarding experience. And finally, it gets you in tune with others suffering, because there are people who live like that, who simply can't afford to feed themselves regularly and in a predictable manner.
Thank you.
Excellent. Dr. Aluya, you're next.
Yes, thank you. And for the Ramadan period, and one of the things that people tend to forget as well, before I go into the question we were talking about earlier on, is the almost what we'll call the binge eating before and after the period of fast. And a lot of people imbibe high carbohydrate food and even salt and a whole lot of stuff. So rather than people losing weight, you find out they gain weight. And we've had some people who eventually go on to develop heart failure subsequently, because the body from 11 months, being adjusted to one thing, and then all of a sudden within a month, it's bombarded with something else. And that's some of the issues that I've had to talk with my Muslim brothers. And I said, something we need to begin to think about, sit down and write about precautions before getting ready for the Ramadan. It's important as well. And I guess Dr. Kareem and anybody else who will be ready to work with that, let me know. I'll join you so we can put some people out to get yours ready. Now, coming to preparing for surgery, it's important because that's one of the most stressful time in any individual's life. I mean, even as physicians, we're human beings as well. And God forbid they tell us we have to have one surgery or the other for one particular illness. we'll be stressed. Our cortisol level and dopamine and everything else will rise up. And it's not just for us as well, but for our family members, your loved one, your spouse, your children. They get stressed as well, especially if it's what do you call it, a scheduled surgery. But we need to understand that as patients, as we put ourselves there, or even as patients that we take care of, one of the advice I always would say that everybody should get a primary care physician. You have to get one, so that your primary care physician is the custodian of your health. If you go out there and an orthopedics or a bariatric surgeon or whoever, even the primary surgeon, maybe the one who referred you to the primary surgeon that else, like I often do. Then you come back and have the sit-down talk with your healthcare provider, so that the issues that predisposing you to needing that surgery are discussed. If it's for cancer, it's for surgery to lose weight or everything else. Now, the other pre-morbid state would also be addressed: the diabetes, the high blood pressure, everything else, hypothyroidism leading to all that, and when to take your medication. And we have some individuals who are also on blood thinners, on aspirin. Some surgeries have been canceled because the individual failed to take off the Plavix or the aspirin before the surgery. So having a primary care physician who you sit down with and have a face-to-face personal touch and talk with that individual. Now, it's apprehensive in the sense that a lot of people come to the doctor and they forget stuff. So what do I say? Sit down, write the stuff down. You can write everything down as you go so that you don't forget. And these are the things that are important, because unfortunately enough, I've had some patients who go for surgery and come back and I say, so what did they do for you? I don't know. I'm like, are you kidding me? They took you to surgery, took something and you have no idea? Well, they didn't tell me. I have no idea. Now it falls upon the doctor, who's the primary care, to call on the physician. And if it's the same hospital, then it's easy. You can look up the notes. But that takes time of the time that we could spend addressing very important issues that pertains to that individual's life. And thank you for Dr. Bay for reading that. And that poem is so important. It's very touching. And I appreciate that. Thank you.
All righty. We have a question that's come through, and I want to get to this several questions actually.
Omar?
Yes, go ahead, Dr.
Omar, before you go to the new question,
yes.
Can I address just one aspect of the previous
you
question?
Sure may, Dr. Ashley. Go ahead.
Yeah, my hand was up a little bit. Yeah, certainly some time ago, we raised the question of trust. And I want to talk about the relevance, importance of trust, and the generation of trust. I think that part of the patient, a lot of patients come by way of referral. The first part of trust, of course, is in terms of you're being referred by someone whom the patient already trusts. That's part of it. Then once the patient comes to you and you have to explain a procedure that you will do, then the way in which you explain the time taken and the utilization of your language skills also goes a good way in generating trust. I find it very important to achieve the trust of the patient for a multitude of reasons, but in my particular specialty as an interventional cardiologist, I have to recognize that when I put a tube when I explain to a patient, I'm going to put a tube in the arteries of your heart and get rid of a blockage there, and I explain the potential complications, that the patient, in order to go through this properly, has got to exhibit a certain amount of trust. Indeed, the other aspect that is always bothersome is that when you go to do the procedure, there may always be unexpected consequences or occurrences that you find or that happen during the procedure. And in order to be able to proceed smoothly without your hands being tied, you have to have generated the trust of the patient so you can go ahead and do what you consider the best under circumstances that you may not even have been able to articulate to the patient beforehand. I go in to fix one artery, I find 3 arteries bad, I find patient having arrhythmias or irregular heartbeats, et cetera, et cetera. I have to be able to have my hands free to go ahead and proceed and do things that I may not have had the opportunity to explain in detail before. But if the patient trusts me, the patient trusts that I will do the best for them, even when they're on the table under some form of anesthesia. Trust is extremely important before I can safely perform a procedure on a patient.
Excellent, excellent. All righty. Okay, well, let's go. Thank you, Dr. Atherley. I was reading this question. I'm sorry. The next question is, what advice do you have for a woman with vulvar disease, vulvar cancer, actually. Treatment, is it curable? How bad can it get? Pain management when it's not approved. All right, those are the aspects of the question. Dr. Anderson, can you start us off, please?
Yeah, I think, can you hear me?
Yes, we can.
Yeah, I think vulvar cancer is one of those entities that do encompasses all the elements of the conversation that we've just had. And it starts from screening, diagnosing, and evaluating your treatment options.
Patrick, can I stop you just for a minute? Explain what vulvar cancer is. You know what I mean?
Yes.
I mean,
So yeah, I will get to that. So cancer of the vulva has to do with what is the vulva. The vulva is that anatomic area, is that area that surrounds the vagina. It includes what we call the labia majora, or that area around the vagina that has hair, and it extends up to the what we call the pubis, the genital hair pad that most people recognize, and it's always apparent every time you disrobe. It also includes what we call the labia minora, which is the skin tag inside of that area that has hair, that has no hair. It includes the clitoris and the area just above the anus, and to some extent about 1 to 2 inches inside the vagina. There are several disease entities that affect the vulva, some of it chronic and inflammatory, and that causes some skin changes. Some of the terms that are used is lichen planus, lichen sclerosis, and these conditions often happens in the older patients, 60 and older. Unfortunately, some of these conditions, because of the chronicity, does put patients at risk for cancer in that area. The most common cause of cancer in that area, however, is the human papilloma virus. And this is a virus which can be acquired early on in life, but can also be acquired late in life. The issue with the human papilloma virus is there are several high-risk types, and it's the persistence of this virus. And the fact that I mentioned persistence, I should say that about 80% of women or men, when they acquire HPV, they will rid themselves of it. So it's the persistence of the high-risk type, and there is about 15 to 20 high-risk type. The ones that we are more concerned about are the 16, 18, 31, 33, 45, and there are a few others that are high-risk type, but do cause cancer rarely. But the ones that I mentioned previously are responsible for for most of the cancer of the vulva. Now, bear in mind that they not just cause cancer of the vulva. They cause anal cancer, vaginal cancer, cervical cancer, cancer of the mouth, the tongue, and the pharynx, the throat. So it starts with screening, and there are several ways to screen patients. The ways that we more commonly identify and talk about is we screen for it in a vaginal pap smear, but you can also have anal smears, you can have smears of the pineal glands and test for HPV. One of the common presentation of HPV is actually genital warts. The conundrum is genital warts is not typical of the virus, the strain that causes cancer. It's more of a chronic indolent type of a process that's more annoying and can be treated through several different modalities. So with respect to vulvar cancer, the diagnosis should occur whenever a woman, and the male equivalent there is also anal, around the anus or the scrotum, have chronic itching and ulceration, and in most time unresponsive to other medical management. In that situation, a biopsy needs to be taken. Once that biopsy is taken and it's evaluated by a pathologist, and in the best of circumstance, one who understands virology and genital pathology, If there's invasive disease, then it needs to be staged. The primary staging for this is a clinical one, which involves just a physical exam that looks at the location and the size and correlate that with the histology. And what the histology is how the cancer looks. And the term we often use is whether it's poorly differentiated or mild to moderate differentiated. Part of the evaluation involved imaging, which is looking at areas of potential spread. The most common sites are the lymph glands in the groin, but you want to know if there's extension to distal sites, such as the liver, the lung, and possibly the bones. And based on that information, that determines the primary treatment approach. The typical treatment approach, as in vulvar cancer, tend to spread locally first, meaning it gets larger before it spreads to other areas. And if it's limited and of small size, radical surgery is usually the primary approach. So to answer the question whether it can be cured, depending on the stage, most early stage 1 and 2, can be cured by surgery, sometimes complemented by radiation plus or minus chemotherapy. For patients with advanced disease, sometimes radiation first to shrink the disease, radiation in combination with chemotherapy, followed by surgery, often radical surgery, is the best way to go. And yes, it can be cured. In situations where there is disease spread to distant sites, the combination of radiation and chemo to control the local disease and systemic chemotherapy to treat the distant sites is the general approach. Fortunately, today, based on molecular markers and some genomic studies, we can also complement some of these surgical and systemic approach with targeted therapies, some therapies that targets immature blood vessels, some therapies that bolster the immune system and recruit your immune system into the fight as well. So to answer the question, can it be cured? Yes, it can be cured. The cure rate is fairly high in early stage disease. Obviously, the cure rate is much lower in the 15 to 5% range in patients with advanced disease. There is a litany and multitude of treatment approaches that's beneficial. And then there's the part that comes to, if I'm going to have surgery, how do you advise patients? Because one of the big thing with the surgical management of vulvar cancer historically is the psychosomatic sequelae or fallout from some procedures which can be somewhat disfiguring. I know Dr. Clark and I has participated in some of these radical surgeries where we actually have to do some reconstruction, mobilizing skin and fat and muscle to reconstruct the vulva to make it at least looks presentable and functional. We've often gone back and have to do exenterations for patients with recurrences of vulvar cancer, where that includes removing the bladder and the rectum. And the result of it is, while we may cure half of these patients, there is significant life-altering effects to some of this approach. So in preparing these patients for surgery, we often send them for counseling. We send them to psychiatrists. They have nutritional counseling, and obviously the medical aspect of it needs to be addressed. These patients need to be optimized. In some of these patients who have unresectable disease and disease that's resistant to treatment, the palliative component is significant. How do we help someone live with the condition with the best quality of life possible? And oftentimes this includes having to do urinary diversion, stool diversion in order to keep the area clean and uninfected. Pain management becomes a big issue. And part of the pain management piece of it is the inclusion of not just the pain management specialist, but also the psychiatrist. Some of this also include the neurosurgeons, because we often recommend an implantable pump that helps us with regional continuous analgesic control. So it's one of these conditions that really harvests all the specialties that's available in medicine to help patients live with this condition.
Patrick, the same person, I think, is the same person came in with further information saying, I do not have HPV, they're 64 years old. Does that change the direction of treatment or how you approach the patient any?
Not really. What it changes is continued management, because someone who does not have HPV-related disease, if you gain control, there are two things that happen, and they're parallel phenomena. One, the risk of these vulvar inflammatory conditions that put this patient at risk will need to be continued to be addressed, usually with local anti-inflammatory treatments. So it's not just treating the cancer and you're finished. You have to go back and continue to treat the lichen sclerosus. With the HPV issue, the parallel is the chronicity, right? And remember, we get there because of persistence of the infection. And it's an infection that we just don't treat and go, and it goes away. So we have to constantly look for areas where it's manifesting itself. For good or bad, with HPV, there's often a pre-invasive condition that can be treated with just local management using various types of intervention, which varies from, laser use to, small local resection to local immune modifiers that will help. There's a parallel, but the causative condition is different.
Okay. I heard you say something about the pain management, and it seems like pain is a big issue. Would Dr. Daniels be one of the people that you would be working with to help solve the pain of that lower, or?
Yes, so what some of what we look at, yes, so this patient has incurable disease that's unresponsive to treatment. And one of the things you look at is, do you offer systemic pain management, or do you offer just local, or a combination? And often this, what influences this is life expectancy. So if this is someone who is still fairly healthy, whose life expectancy is more than 3 months, maybe this is someone who may benefit from an implantable pump. So this is when I would, liaise with my pain management colleague, who would then consult with Dr. Daniels to see if one of these implantable pumps would be beneficial.
Dr. Daniels, I'm not familiar with these implantable pumps. I don't know if you've done any, but can you give us some enlightenment how that helps a person with pain?
Yeah, there's actually a couple of ways to treat the pain. So one way is to do a pain pump, which takes the same type of narcotic that you would take systemically, the same type of narcotic that we would put in IV, or the same type of narcotic you would take in pill form, that would then diffuse in your bloodstream and go to your pain receptors and try to block pain. Well, we can do a much stronger concentration of that locally in your central nervous system by implanting what's called an intrathecal. Thecal is the sac that covers the nerves. So inside that sac, we can take like an extremely small amount of a narcotic. Morphine is an example of which that we can place in there, and we have a pump with the battery associated with it that gradually administrates that type of medication. You do that at a level where it can affect the organs that are experiencing pain. So if we're talking about pelvic pain, you would do it at a level of the upper lumbar spine. You would place that pump in there, and it would gradually administer that medication at a high concentration and a potency that will then numb that area below that area. There are other ways that you can do that as well. You can ablate, you can go a little bit higher, and you can ablate the pathways of pain that occur in the posterior portion of the spinal cord. It's called a cordectomy. That as those pain signals reach from the brain down to the area lower than the brain, you can interfere with those pain signals. It can decrease the pain. And then you can do a spinal cord stimulator, which creates an electromagnetic signal in the posterior, the back portion of the spine, to interfere with those pain pathways as well. You can do these things just like any other surgeries. These things have risk associated with them, and there's cost associated with them. And they're typically palliative, meaning you do them because there's no other surgery that can directly correct the pain. But there is a question of how long someone's going to live and whether it's worth it to expose them to this risk if they're not going to be alive for a very long time.
Yeah. Dr. Salam, this seems like it can be a chronic type of problem, and dealing with cancer, if it's cancer or not, how do we approach a patient psychologically with something like this? So really, in this area of the body in a chronic situation.
Well, before I get into that, I want to make sure I'm understanding what Dr. Daniels said properly. It sounds like you have the local application of narcotics or possibly opioids, and where you're getting the analgesic function or the pain relieving function of the opiates without necessarily getting the associated euphoria that could heighten the risk of addiction. So I think that's an important point to convey. Is that accurate, Dr. Daniels?
That is very accurate. Yep. You don't get this medication in the brain itself. You only get this medication surrounding the nerves that essentially blocks the pathway from your brain receiving the pain. Where the addiction comes is when you're getting this medication in the brain, and the brain begins to adjust and alter itself to accommodate for this new chemical that then leads to tolerance and dependence. So yeah, it is a local phenomenon that does not lead to dependence.
Yeah, the other advantage of doing it this way is there's also some other systemic effects, such as constipation that comes with use of these opioids. That, if you can imagine, having pain and dysfunction in the pelvis, adding constipation to it just adds to the discomfort.
And thank you, Dr. Anderson. And to address the concerns that Dr. Bay raised, chronic pain could be extremely frustrating, even in the best of times, and in the worst of times, it could be life-threatening. So chronic pain could be debilitating. It could affect your mood. It could affect your outlook, your worldview. And sometimes, particularly when you're dealing with cancers that have spread throughout the body or metastasized or have spread to the bones, that type of pain could be unbearable. And in many cases, folks find just want any type of relief possible, because with that level of pain, some people can't even function. You can't even earn a living. You can't work. You can't pursue your avocations. So, pain could affect you from a stress standpoint, in addition to your mental health and your ability to heal if you have underlying chronic illnesses. So to the extent that that could be managed safely without creating other risks like addiction, those could be really effective interventions.
I want to get to you, Dr. Garrison. But first, I want to talk to Dr. Lee. Dr. Lee, you deal with chronic pain all the time. And as far as addiction and pain meds, how do you handle that? And then Dr. Garrison, you're next.
It's not easy. I think, it's a complex pathway when the body has developed dependence and the patient's behavior, the lifestyle can revolve around addiction. In the setting of an elective surgery, and we recommend narcotics or pain control for afterwards, I think you create expectations and say, I expect for the first 2 or 3 days, your pain is going to be, 8 to 9. It's okay to take the medication. And I think what happens is people become addicted when they take the medication when the pain is better, but they continue to take the medication. And so when there's a surgery, when there's some type of physical insult, intervention performed, yes, it's justified. But when you continue to take the medication, when that pain changes or lessens, that's the issue. In the orthopedic world, if that patient remains on narcotics at 30 days or longer, there's about a 50% chance of them becoming addicted. So we try to get ahead of it and say, listen, the first 2 or 3 days, yes. The state of New Jersey has been reasonable with not allowing us to prescribe heavy amounts and initially, and then the refill also has to be authorized. And so I think if you can create patient expectations that are reasonable to say, listen, it's okay to take narcotics when you're in pain. But when that stops, we're going to get you on something that doesn't have narcotics, such as Tylenol, and anti-inflammatory. Meditate, think, educate the patient that, there's not just a medical fix for it. There's other ways, behavioral, there's breathing, there's thinking, there's talking, discussion, so that it's not just a pill that is a fix. When we deal with somebody who comes in already on, narcotics, it can be tough because they may have an orthopedic issue that needs intervention, and you may do a great job, but they still are on that medication regardless because their body is addicted to it. So then it's like, all right, should we do it? Should we not? And it's not a cut and dry discussion at all.
Excellent, excellent. Dr. Garrison, please.
I don't want to be redundant, and I don't, and I don't want to, everything that Kareem and James and Lawrence have said, I was going to say as well, but so I'm going to steer away from the narcotics. But I think there are some preoperative things. What I found was preoperative preparation and preoperative drugs do work. I face two sets of patients. Sometimes there's a socialization of that narcotics don't work unless you get high. And then there's the other socialization of I don't want any narcotics because I don't want to get addicted. And there is, reasonable guidelines for use of narcotics. But what I've found is certain drugs, like when I do the bariatric surgeries, I give an intravenous dose of Toradol, which is a non-narcotic, prior to the surgery. And then I give 2 doses after the surgery. And I have found that it cuts my narcotic use down to less than half. Sometimes no narcotics are necessary at all for these major surgeries. So there's things like that. And Dr. Lee talked about, some patients biofeedback for chronic use. Dr. Salam has other things that he can utilize. So narcotics in themselves are not bad. I think what is bad is bad surgeons and their use of narcotics. I went to a practice and routinely they were right for 50 Percocets for somebody after surgery, and Dr. Lee talked about the state of New Jersey clamping down on that usage. The number one criminal offense in Morris County was stolen prescription pads and the use of illicit drugs writing. So I try to avoid narcotics. They have their place and they're a good set of drugs. But if there's alternatives to it, I try to employ those alternatives as much as possible.
Omar, if I might say something that parallels what Dr. Garrison says, I know, and Kevin, you have similar experience. We go on these mission trips and we do operations on patients. And they may get a dose or two, we don't use it much anymore, but Demerol post-op. But the next day, they're up and they're out of there with the equivalent of Tylenol. So I think, there's also an environmental component, what people listens to, hear, and their expectations. We've seen some of the orthopedic surgeons who go on these mission trips. They do major reductions, and a lot of these patients are going home with minimal to no analgesics, or just on a as needed basis. And they use what's available to them, and oftentimes it's non-narcotic medications.
Excellent. And since you brought up mission trips, I want to give a shout out to our mission trip, Guyana Medical Mission, that we go in November. And many of the docs here go to this mission trip for a week, and we work hard, see a lot of patients. And one of our esteemed physicians, he signed off, but Dr. Court, James Court, he is our team leader. He's the initiator of all of this, and we look forward to going back to Guyana in November. Can't wait. Patrick, you'll be there.
Yep.
And Dr. Clark, and boy, we'll rock and roll.
I like to take Dr. Daniels and Dr. Lee sometimes when we it's a lot of good stuff.
I feel
love it.
left out. Nobody told me about this.
All right. Oh,
let me tell you, there's a lot of vein stuff you can do. I just need for you to have what you need.
Well, let me know, man. Let's sign me up.
It's so good. It's that our mission to Guyana is excellent, and boy, it's so rewarding, and the patients are just so thankful. It is such a rewarding experience.
Can I get some pepper pot while I'm there?
That depends on how far you're willing to go to get it. You may have to take a boat up to the quarantine to get it. I never know where that is, but
Yeah.
but it's a lot of fun.
It's a lot of fun. All right, then. So thank you, each and every one of you, for coming on again. Believe me, I can't wait until the second Saturday of next month, because this is such a joy. Each and every one of you, thank you to the bottom of my heart. I would like to close with, I would like to thank OBHealthy for allowing us to bring this product, bring this webinar to you. This is such a great platform. Remember, every second Saturday at 1 o'clock, we're here. Please tell friends and family. We're here. That's every second Saturday of each month, I should say. Remember, caring is sharing is so important. All righty. The most important thing I should say is, do not change any aspect of your medical care until you consult your physician. All righty. And until next time, thank you, each and every one of the physicians, with being here with me. I'm going to say peace and have a safe month. We'll see you next month. Peace, everyone.
So.
Bye-bye.
Bye-bye now. Excellent.